You're listening to Medscape's In Discussion series on colorectal cancer, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Benjamin Schlechter. Dr. Schlechter is an academic medical oncologist at Dana-Farber Cancer Institute and instructor in medicine at Harvard Medical School. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Benjamin Schlechter, and welcome to Medscape's In Discussion series on colorectal cancer. Today, we're discussing systemic therapy for advanced colorectal cancer with Dr. Diane Saverese. Dr. Saverese is a recognized expert in GI oncology and recently retired from a long career in which she served as the GI oncology editor at Up to Date. She was a senior member of the Division of Hematology and Oncology at Beth Israel Deaconess Medical Center and helped lead the oncology program there. And she was also a member of the Faculty of Medicine at Harvard Medical School. She's well known for her encyclopedic knowledge of GI oncology in general and colorectal cancer in particular. But before we go to our discussion, Dr. Saverese, I'd love to hear a bit more about your path to becoming a GI oncologist.
Sure. It was actually quite circuitous. My undergraduate degree is in pharmacy. And when I finished my 5 years of pharmacy school, I took a part-time job as a cancer researcher at Roger Williams Hospital in Providence, Rhode Island, where I worked with Ellen Spermuli and Dan Dexter, who were very instrumental at the very beginnings of tumor biology. Subsequently, I applied to medical school, got in, and then during my residency at Hopkins, I was involved in the care of a lot of cancer patients and met wonderful people like Russ Donhauer, who really stimulated my interest. So I joined the fellowship program at NCI. That was during the Snuffy Myers and Bruce Chabner years. And at that time, AIDS and AIDS-related cancers were very prominent. And it's because of that I didn't become an infectious disease doctor, because that really was my initial love. So I took a job at UMass after that. That was in 1989 to 90. And I focused mainly on prostate and GI cancers because that was the niche that needed to be filled there. So after 10 years there, I was lured away to Up to Date by Bud Rose, who was the founder of Up to Date, and he was a nephrologist at UMass. And I was the inaugural editor for oncology. It's hard to believe, but I actually did all of solid tumor oncology plus Hodgkin's disease for about 10 years. I subsequently took a faculty position at Harvard in a part-time clinical position at Beth Israel, again, focusing mainly on sarcomas and GI cancers. And here we are. And
I have to say, as a former fellow of yours and as someone who still calls you for advice, I think you are really one of the most valuable voices in this community.
Thank you.
So let's talk about colon cancer here. So when we think about advanced colorectal cancer, there's a lot of categories that we can talk about. There's ways to divide out this disease. We've addressed important but sort of less common subtypes like HER2 amplified disease, the role of immunotherapy. And those are valuable and important discussions, but they really dig down on a few percent here or there. When you're seeing an average patient with colorectal cancer, how do you break down this population? How do you think about these individuals?
I think the most important broad concepts are that there is no such thing as a one-size-fits-all approach to advanced colorectal cancer in the initial therapy. And the way I break down patients in treatment decisions is in three ways. I look at the molecular characteristics of the tumor, and the most important of those in the front line are RAS and RAF mutations and deficiency in MMR, which of course indicates the likelihood that the tumor will respond to checkpoint inhibitor immunotherapy. But there are a couple of other broad categories that I consider. One of them is the burden and location of disease, as well as patient factors, the most important which are fitness level, which depends on comorbidity and performance status, and the patient's values and preferences have got to be considered tantamount in all of this, especially when it comes to counterbalancing the toxicities and survival benefits of these treatments. One of the more important things is the status of the patient's tumor as regards potential resectability. And I'll just give an example of how that works. If you have a patient who has potentially resectable, but initially unresectable disease, you want to choose a regimen that has the highest response rate you can get, because that's the way you're going to get that patient to resectable state and potentially giving them the possibility for long-term survival. In contrast, if you have a patient who doesn't have a hope of having a resectable disease, the most important endpoint to focus on is progression-free survival, because you want to achieve as long a period of disease control as is possible so that you can maximize the number of treatment regimens that you're able to offer to that patient.
Excellent. How do you think about initial decisions, doublets versus triplets, right-sided versus left-sided? Like, when do you choose FOLFOX and FOLFIRI and FOLFOXIRI? Let's start with the chemo backbones before we talk about some of the monoclonals.
The chemo backbone nowadays entails a description of triplet therapy, which includes oxaliplatin and irinotecan, in conjunction with a bevacizumab or anti-EGFR agent. Those are the two classes of biologics. And the issues that come into play there are dependent on the robustness of the patient population, because FOLFOXIRI, the triplet combination, is a pretty tough regimen, especially when it's combined with bevacizumab. And we want to make sure that we're not going to trash the patient in trying to trash the tumor, because there we've not made any headroads at all. So the first decision-making point is, can this patient tolerate the heft of triplet therapy? And then the second factor is where the clinical situation is, and that has to do with, in my eyes, the resectability of the primary tumor, because triplet therapy, especially combined with a biologic agent, has amongst the highest response rates that we see with systemic chemotherapy in metastatic colorectal cancer. But you have to be careful about what you choose. And I'll give you an example of that. There's some data for patients who have potentially resectable liver metastases that if you combine a regimen that includes oxaliplatin, and that includes both the triplet regimens and the doublet, with an anti-EGFR agents, that overall progression-free survival may actually be worse than if you use a different type of combination therapy. So we have to be careful about which agents we combine. And here is a good illustration of the conundrum that we as oncologists face right now. You know, back in the 1980s and 90s, when I first started my practice, we only had 5 FU, and the average survival there was roughly 6 months. So starting in 2000, when irinotecan was approved, oxaliplatin followed in 2002, we now have a tremendous number of active drugs in metastatic colorectal cancer, but it has led to significant challenges, the riches that we now have. One of the biggest challenges is that we're not really sure how to optimally sequence and combine all of these agents together. Another is that sometimes when you combine all of the agents together, you end up with high response rates, but a very modest impact on survival, but a lot more toxicity. And the third thing is that toxicity level. And many patients look at that, and according to their values and preferences, that's not a situation where they really would like to be in, is having more toxicity and impaired quality of life and only getting a little bit of benefit. So the one situation where I think it's clear that the triplet therapy is a benefit, especially in combination with bevacizumab, is in people who have RAF mutated tumors. And that's where there are data that suggest that FOLFOXIRI plus bevacizumab overperforms our doublet therapy plus bevacizumab in terms of objective response rate, overall survival, progression-free survival. And even though it has a higher side effect profile, those 3 outcomes are important for that category of disease, which is very poor prognosis. So in the setting of potentially resectable or borderline resectable metastatic disease, I would always choose the triplet regimen with a biologic agent.
Yeah, and that really gets us to some of these trials that we learn about as fellows and that we see in practice. We see summarized in your section Up to Date, where we have the STEAM trial with Hurwitz et al. And the oncologist in 2019, and TRIBE, which was Kremlini in the Lancet Oncology. STEAM was FOLFOXIRI versus sequential FOLFOX and FOLFIRI, which I thought was a really interesting design. And really the benefit was moderate, but there was something there, especially as you pointed out, in the mutated cancers. And the same thing in TRIBE, which was against FOLFIRI. There was a benefit, but it was hardly as impressive as I would hope for that much extra bang. You don't get a lot of buck.
That's absolutely correct. And one of the areas that is especially unclear, even today, is what exactly bevacizumab contributes to that triplet regimen of FOLFOXIRI, because there's never been a trial that directly compared FOLFOXIRI with or without bevacizumab. And as you know, there are significant toxicities when you add bevacizumab, especially in people who are over the age of 65. The only data we have comes from a pooled analysis of 7 trials assessing the benefit of bevacizumab in conjunction with chemotherapy. And the median overall survival was just 2 months greater with the addition of bevacizumab to a variety of oxaliplatin or irinotecan-based regimens. The benefits of all of these biologic agents have shrunk over time, whereas our understanding of their toxicities has expanded over time. That complicates the choice of therapy.
Now, when you're facing a patient with advanced disease, multifocal disease, for example, and they've had prior adjuvant oxaliplatin, does that inform your decision for a triplet regimen versus a doublet regimen?
I think the choice in somebody who's had prior adjuvant therapy boils down to, are you going to give them FOLFOXIRI or FOLFIRI? And the problem with giving FOLFOXIRI is that we're assuming that because of the prior adjuvant FOLFOX, that what has grown out in the recurrent disease is a population of predominantly oxaliplatin refractory colorectal cancer cells. And in my view, giving both irinotecan and oxaliplatin is not necessarily going to mitigate that. So I think in that situation, I would probably stick with just FOLFIRI and consider adding an anti-EGFR agent if you have a wild-type tumor and your tumor is not on the right-hand side, or adding an anti-angiogenic agent at that point.
Yeah, and speaking of the anti-angiogenic versus the EGFR inhibitors, so, I always struggle with the idea that the thing you give first is the thing you give longest. And we have 3 prospective randomized trials supporting the use of EGFR inhibitors in the first-line setting. Actually, more than 3. We have the Crystal study from Van Cutsem et al. In the New England Journal 2009. We have the MRC Coyne Lancet Oncology paper 2011. That was FOLFIRI with cetuximab and then FOLFOX with cetuximab. And then, of course, we have the PRIME study looking at FOLFOX and panitumumab. These are highly active drugs, but they add a lot of toxicity in the first line. And that's the thing the patient's going to be on longest. It's also very apparent toxicity. In the breast cancer world, alopecia is the way you see the side effect of therapy. And in the colon cancer world, for EGFR inhibitors, we see the EGFR rash right on the face. So how do you think about when to incorporate those agents, which are both effective and toxic, in the first line versus second line?
I think the whole concept of whether or not every patient should get a biologic agent for frontline therapy is an extremely controversial area. As you point out, there's a lot of toxicity involved. And initially, when all these biologic agents came into our level of clinical trials, the trials suggested a lot more benefit from the addition of a biologic agent, either an anti-EGFR agent or an anti-angiogenic agent, than we're currently seeing. Part of the problem is that the initial approval of bevacizumab was in conjunction with IFL, which is a bolus irinotecan-containing regimen that is probably less effective than one of the short-term infusional FU regimens that we use now, such as FOLFIRI and FOLFOX. So as time has gone on and bevacizumab has been combined with more and more active chemotherapy backbones, the benefits of those drugs have really declined and the toxicity profile has increased. The same exact thing has happened with EGFR inhibitors. So I personally use patient values and preferences to decide on whether to add a biologic in the first-line treatment. One of the important concepts of treating metastatic colorectal cancer is that the best survivals are seen in patients who are exposed systematically to all effective agents. Remember, I said back when I first started, median survivals of metastatic colorectal cancer were 6 months. Well, now in the most recent report of the FIRE3 trial, in KRAS wild-type tumors receiving a combination of a doublet plus an EGFR agent, the median survivals are approaching 29 months. And that's a pretty impressive difference over a 30-year period of time. But those survivals are achieved in patients who are systematically exposed to all active agents. One of the problems with giving these agents up front is that patients tend to be less likely to receive more chemotherapy afterwards because they're tough on people. So I prefer sometimes to start with a cytotoxic chemotherapy backbone and then add a biologic agent for second-line therapy, depending on what was given firsthand and whether or not the RAS-RAF mutation status is known and wild type versus mutated, and also the sidedness of the tumor.
Yeah, talk a bit more about this sidedness. Tell me your thoughts. We have several studies, Crystal, FIRE3, and PRIME, all have shown this interesting finding that the biologic predictive marker of RAS, RAF wild-type cancers doesn't follow through on the right, that right-sided cancers can resist EGFR inhibitors in sort of interesting and unexpected ways. So how do you think about that? Do you just try it because you can, or do you really think we should avoid these agents on right-sided cancers?
So the tumor-sidedness issue is something that's been percolating for a very long time. And initially, the data came from subgroup analyses of clinical trials that were not looking at tumor-sidedness as an endpoint. But a really preponderance of evidence now supports the view that if you have a right-sided tumor, and the definition of a right-sided tumor is one that is proximal to the splenic flexure, that these tumors are relatively refractory to first-line therapy with an anti-EGFR agent. And we're only talking about first-line therapy here. There are very few data at all on the effectiveness of EGFR agents for right-sided tumors in later lines of setting. So the best data we have now come from a very well-done pooled analysis that was in JNCI back in 2021 in patients with previously untreated metastatic colorectal cancer. So among the 500 who had RAS wild-type tumors, compared with combination cetuximab plus chemotherapy, the use of bevacizumab plus chemotherapy led to a more than doubling of the median overall survival, 26 versus 12 and a half months. That's an astonishing difference. In contrast, if you looked at left-sided tumors, there was absolutely no difference between cetuximab plus chemotherapy or bevacizumab plus chemotherapy. So the bottom line is, if you are going to use a biologic agent as part of your first-line regimen, if a patient has BRAF, RAS, wild-type tumor, and a right-sided primary, I would choose bevacizumab. Whereas if they have a left-sided primary, you can either choose Bev or an anti-EGFR agent, again, depending on the patient's values and preferences.
So, we really live in an era where we're trying to refine toxicity, refine benefit. It seems clear that escalation of therapy in the first line is not for everyone. And we've seen this in a number of ways culturally in colon cancer, even going back to early stage disease, where we have the IDEA Collaborative looking at de-escalation of 6 months versus 3 months of adjuvant therapy. We have the Prospect trial in rectal cancer. We're trying to avoid the toxicity of radiation in a subset of selected individuals. In the advanced disease setting, we also face the conundrum of when to stop, how much chemo is enough, the role of maintenance therapy, the role of observation off of therapy. So how do you palliative de-escalate in the advanced disease setting? How do you do that?
So I think of this question of intermittent versus continuous therapy. And up until a few years ago, we basically treated people with the first-line regimen until they developed progressive disease. And in some cases, they were on chemotherapy for years, because if they had particularly indolent disease or a low amount of tumor burden, they could be on therapy for quite a bit of period of time, and it was unclear when the stopping rule was. But largely as a result of efforts to diminish the toxicity of therapy, folks have been looking at different ways of mitigating, especially oxaliplatin neuropathy, which is, of course, the cumulative and often dose-limiting effect of oxaliplatin. So all of the trials looking at intermittent therapy initially focused on oxaliplatin, and they followed two paths. They followed the path of maintenance strategies, which is giving an oxaliplatin regimen for a period of time and then taking the oxaliplatin away and leaving the patient either on leucovorin-modulated 5-FU alone, with or without bevacizumab, or 5-FU leucovorin with bevacizumab. There's also some data on when EGFR inhibitors were also part of the initial treatment. Taken together, all these studies support the view that survival is not adversely impacted by using periods of maintenance chemotherapy without oxaliplatin, and the toxicity is clearly improved. So more recently, trials have been looking at whether or not you can go with a complete break in therapy without having to use a maintenance regimen. And again, in general, we have 2 meta-analyses that have demonstrated that there's no adverse impact on survival and toxicity is better, although progression-free survival may be short. As an example, in the FOCUS-4N trial that had a variety of regimens used and compared to using capecitabine alone or a complete stop after a fixed period of time, that median progression-free survival was 1.9 months in the group that had a complete break in therapy. Parenthetically, it was 3.9 months in the group that underwent maintenance capecitabine, which isn't that much longer, and that group had a lot more toxicity. So this to me is a discussion that's, again, highly dependent on patient values and preferences. If you're going to do this, though, it's important that you make certain that the patient has responding disease, doesn't have a significant tumor burden in a critical site, that if it grows during complete break in therapy, the patient's going to be in trouble. And you have to maintain close surveillance to make sure you're right on top of things when the disease starts growing back, because then you reintroduce the drug at the time. The benefit of intermittent therapy with irinotecan-based regimens is far less clear because there's really no cumulative dose affecting toxicity with those regimens, but they can beat up people, especially if you're on an EGFR containing one. So in my own practice, I treat patients as long as they're responding and tolerating therapy, but then when the tumor starts being stable, I stop, and then I continue watching the patient and restart the regimen afterwards.
Yeah, I think both Optimox and Focus 4 give us some guidance because they look broadly at this question of maintenance therapy and stopping therapy. But when you dig deep, there's a couple nuances, right? Patients were seen for a clinical evaluation monthly with imaging every 8 weeks. I think that's really important. And what I've learned in my own practice, and I'm sure you've seen this as well, is patient selection here is critical. Willing patient who's not going to worry about being off therapy. You need a patient with moderate volume disease. Perineal disease is not a great place to stop. Bone disease is not a great place to stop. But I think for the right patient, the willing patient, the motivated patient, I think it's a good opportunity to focus on quality of life, knowing that you've got the chemotherapy, you can use it later, and knowing that you don't lose anything as long as you watch closely. So today we've had Dr. Diane Saverese joining us discussing systemic therapy for advanced colorectal cancer. We discussed doublet therapy versus triplet therapy and combinations thereof. We talked about the critical value of boosting efficacy for patients where you're considering resection, but the concerns raised over EGFR inhibitors and resectable disease. We talked about how EGFR inhibitors, panitumumab and cetuximab, have less benefit in right-sided cancer, certainly in the first-line setting. We talked about areas where we can use these regimens. We discussed that chemotherapy and these monoclonal antibodies are valuable agents to use, but they have a significant impact on quality of life, and that patient selection is really, really important, accounting for the risk profile of the patient, as well as the values of the patient and what they want out of their treatment. And that's, of course, always a very critical discussion. And finally, we talked about stopping and starting chemotherapy. There is value in a break. Doctors need vacations, and so do patients. And I think it's an important lesson for all of us. So thank you for joining us. It's been a pleasure hearing your thoughts and your wisdom. This is Dr. Benjamin Schlechter for In Discussion.
Thanks for listening to Medscape's In Discussion Colorectal Cancer podcast series with our host, Dr. Benjamin Schlechter. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on colorectal cancer.